since Dr. Werner was talking about bipolar, I'll just start with the mood stabilizers. And these three are kind of the standard mood stabilizers that we use when we're treating somebody with bipolar disorder. So Depakote, lithium, and Tegretol seem to have the most efficacy. And then we also can sometimes use Lamictal, and Lamictal is sort of a special case. So with these three, we tend to draw blood levels for patients that are on those medicines to make sure that they're not getting too much or getting toxic from them. And we can also kind of notice if they're in what we call a therapeutic range, a range where typically people are doing well. And if you look at big groups of people with these disorders on these medicines, they tend to do well in that range. Or like with Depakote and Tegretol, they are anticonvulsant medications, so we treat people that have seizure disorders with these medicines. And we're also kind of using that range to know when would someone be safe to not have a seizure. And there's sort of a theory that bipolar disorder is somewhat like seizures in a way. If you look at it over a period of time and scrunch that time together, it can look a little bit like how a seizure might act. Oh, the question was how long can you stay on these medications? Sometimes it can affect your platelets, so there's a lot of monitoring that you have to do when somebody's on these medicines to make sure those things aren't happening and that it is safe to continue taking them. Same thing with lithium. It can affect the thyroid and the kidneys, so again, you just sort of are monitoring those over time, every 3 to 6 months, to make sure those things are staying at good levels, and sometimes we do have to make changes. One of the hardest parts is just convincing patients to continue taking them because of side effects that are uncomfortable for them. Weight gain is one. Feeling slowed down would be another one. Tremor comes up with lithium. There can be a little tremor that comes in both hands that can be frustrating. Fatigue or feeling sluggish. So yeah, we can talk about Lamictal. It is somewhat newer medication that we use in bipolar disorder that has been really helpful actually because it helps to treat the depressive episodes and the depressive symptoms that come up in bipolar disorder. And I think Dr. Werner mentioned earlier that sometimes using antidepressants in people with severe bipolar disorder can really cause them to go into a manic episode. So it's been a struggle when people with bipolar disorder are suffering with depression and there really wasn't good medicine to help them out of those depressive symptoms. But Lamictal has been something that works really well for that and doesn't have a lot of side effects. The important things about Lamictal, it has a really low risk, but would be a low risk of getting a rash. The problem with the rash is in a small number of people, it can be a life-threatening rash. So you have to go really slowly with that medicine. And if you stop the medicine, you have to go back to the beginning, starting at a low dose to make sure that you're not at risk again for that potentially life-threatening rash. So how long does Lamictal take to start working is a question. It takes time because of the risk of the rash. We start at a very low dose and then very slowly move up over the course of weeks. So I would say a typical dose is often about 200 milligrams, and you really start at about 12, in kids about 12.5 milligrams, in adults 25 milligrams, and move up every week. So again, some people get a positive response at 50 milligrams, but some people need more, like 200. Some people need up to 300. I know you had someone that needed up to 600. So it depends on the person, but in general, it takes a while to move up, and you have to take time for that safety risk. So the mood stabilizers aren't too big of culprits in diabetes. You can get weight gain with Depakote and with lithium, but I think where that comes up a lot with psychiatric medications are the antipsychotics. The atypical antipsychotics really do have problems with weight gain and with metabolic syndrome in general. So that's sort of like pre-diabetic states. The question being, how does Lamictal help with manic states? And there is some evidence that it can help decreasing hypomanic states, but it's really not a medicine that's going to keep someone from having a manic episode. Or if someone were to be in a manic episode, that wouldn't be a medication that would be helpful to kind of taper off or get rid of those symptoms very quickly. And sometimes too much Lamictal can make someone feel a little bit too bubbly or goofy. So it's not very useful in treating mania. What's Invega for? And that is an atypical antipsychotic. So that would be for treating psychosis. Maybe I should just talk about those now? Yeah, okay. So help treat the psychosis that's happening. So take away some of those extra symptoms like auditory hallucinations, visual hallucinations, delusions, and a lot of those bigger unrealistic ideas. So there's kind of two groups. One's called typical and atypical. The typical antipsychotics are just the older antipsychotics. Basically, they were developed first, and they're things like Haldol, perfenazine, Trilofan, and then Clozaril really was, I guess, like the first atypical antipsychotic. And the difference between them is that the first group causes a lot more of the movement disorders and some rigidity, and the second group has less of that, and that is why they are atypical, in that they have less of those movement disorders. So, but the atypical has its own group of problems, and that's the weight gain issue for most of them. So what kind of symptoms would be helped by Invega? It could be a pretty big range, but things like auditory hallucinations, visual hallucinations, delusional thinking, sometimes lots of ruminations or intrusive thoughts that are just really hard to break or slow down for the person. And the other thing is with the atypical antipsychotics is it seems like they do add a little bit to mood stabilization as well. So some of that as well. So the question is about the movement disorders with typical antipsychotics. So you can get, sorry? With atypicals. So it's less so with the atypicals. You just don't see as much of what was called tardive dyskinesia or late onset movement disorders that happen with the typical antipsychotics. I think what happens mostly with movement disorders with the atypicals is extrapyramidal symptoms, or what we call akathisia. So that's when you initially get on the medication, you can feel a little bit antsy. A person might kind of move like foot to foot or feel like they need to pace all the time, not be able to sit very comfortably in their chair. And these are typically things that happen when you first start the medicine, and then those tend to get a little bit better with the atypicals. But with Risperdal, that is one where you can still get some rigidity in your muscles, or cogwheeling, where they're really stiff in their muscles. That would probably be the biggest offender with the atypicals.
Abilify is pretty bad.
Abilify has lots of akathisia for people when they're first getting on it. Some people not at all, but just extreme restlessness where people describe wanting to jump out of their skin, and just it's very uncomfortable. They feel very crazy, and it can lead some people to just wanting to run and jump out of a window because they feel so antsy. So we have good treatments for it with another medicine, actually. So something like Cogentin helps very much. Benadryl, propranolol, all those things really tone down that nervous system that's gotten so overactivated by the medicine, and they work really quickly. Mm-hmm. The question is, are there some people that are resistant to antipsychotics? Yes. I'm thinking of one person that we treated that, we tried everything in every combination, and there were moments of some of the delusions decreasing in intensity, and behaviorally that person got slightly better, but overall there just was not a lot of benefit. I don't think that's real typical, but it does happen. I don't know what you think.
Can I just make a comment? When we see people who don't respond to antipsychotics time and time again, often we will move on to clozapine, which is the one antipsychotic medication that works when the others don't. But if that doesn't work, one would become very suspicious that the underlying condition perhaps is not we'll say schizophrenia, but an affective illness like bipolar disorder or a schizoaffective disorder, depressed. And when we see that happening, we often will figure that we want to treat the affective component assertively. And when we see a lot of cases like this, because we see a lot of cases that have failed to respond to treatment in other facilities around the country. And so we're often looking for that underlying depressive disorder with the negative delusions and hallucinations. We might treat that depressive illness with an antidepressant medication, for example. And the interesting thing is that these are psychotic illnesses, but you don't have to use necessarily an antipsychotic medication to tackle the problem. You can tackle the affective component and treat that effectively with a mood stabilizer, with an antidepressant, and discover that the person gets better and really doesn't respond to the, doesn't need the antipsychotics. That's a very good question. There are no antipsychotics that don't work on the dopamine system, but the atypicals are more selective on which parts of the dopamine system they work on, and that's why they're less likely to cause the side effects that you'd get with them acting on producing the basically Parkinsonian-like symptoms. So they work on the limbic system, but not the nigrostriatal system. Emil Kraepelin, back in the late 1800s, worked in a German asylum, and he sorted out these people with what we described as functional psychoses into those people who had the typical course of what was then called manic depressive illness, and then the other ones who didn't have that course, and he called that dementia praecox, which later came to be called by Eugen Bleuler the group of schizophrenias, indicating in fact there were many different conditions in there. And he called it dementia praecox because he saw it as a condition that got progressively worse the older you got and you went downhill. And in fact, that's the opposite of the truth. It happened with his patients because they were in a prison-like asylum. And in fact, schizophrenia, the good news is it's an illness that gets, in general, milder the older you get. So people with schizophrenia are generally worse when they first have the illness and they're in their 20s. And by the time the person is 50, he or she is likely to be doing a whole lot better. And that's partly because the brain adapts and the person adapts and develops coping mechanisms. But it really has the opposite tendency compared to bipolar disorder, because bipolar disorder, the episodes get closer together and more severe, but in schizophrenia, the symptoms tend to get milder in general. So schizophrenia is, one of the characteristic features is what we call thought disorder, meaning that the person may not be able to answer to the point. He may be illogical or rambling in his response to questions. His answers may be very odd and off the point, and sometimes you can demonstrate it by asking the person to interpret proverbs. So this morning I had a young man, and I wasn't sure, in fact, if he clearly had been psychotic. I wasn't sure if he still was experiencing psychotic thought disorder, so I asked him to interpret some proverbs, and one of them was, what's it mean, out of the frying pan into the fire? And his answer was, well, the fire would be in your belly, and that's where the food goes, which clearly was not a logical answer to that request to interpret a proverb. So sometimes that challenge of asking someone to come up with an abstract form of thinking brings out the thought disorder in a very clear way. A person can have a thought disorder like ideas of reference, where you think that something that's happening out there somehow refers to you, when in reality it doesn't. So I recently heard somebody talking about a lady who's a musician who was suffering from psychosis, and she was listening to the radio, and the first piece of music she heard was by Schubert, and the second piece of music was by Schumann, and so she decided that the radio was telling her to go out and buy a pair of shoes. So that's the kind of misinterpretation of events. Or you might think that you're looking out the window and you see 3 white cars go by in a row, and that's the sign that the FBI is watching you. Or somebody comes on the radio or the TV news talking about the war in Afghanistan, and you think that that somehow is referring to you, and some violent act is about to happen to you yourself as a person. So those are some examples of thought disorder, which are particularly common in schizophrenia. So sometimes people come to me having been diagnosed with schizophrenia, but in fact they don't have that really important component of the schizophrenic illness. And when that's the case, when the person is quite logical and their thoughts are linear and tied together well, that's when I'll begin to suspect that the delusions and hallucinations and so on are perhaps coming from affective psychosis, from a depressive illness. So that thought disorder is really very important. In addition, of course, the person may have hallucinations, will likely have hallucinations and delusions in schizophrenia, but they're more likely to be neutral in content. They're less likely to be critical. So, for example, you might hear voices commenting on what you're doing, or voices telling you what to do. You might have delusions of things going on that are not specifically unpleasant in nature or pleasant in nature, as in the phases of bipolar disorder. They may certainly be paranoid delusions. That's really quite common in schizophrenia. And you may think that you're being followed or watched, or these days you're being watched by cameras and being your image is being shown on the internet, or that people are watching. Hundreds of people are watching you on the internet all across the world. When the delusions are particularly bizarre, like you're in contact with Chinese generals in outer space, or completely illogical, like I was born in Denmark to the King and Queen of Denmark, and these people who call themselves my parents kidnapped me at an early age and brought me here. And I was born in 1827. And how old are you now? I'm 21. I mean, that kind of completely illogical, bizarre, can't put it together, is something that you'd be more likely to see in schizophrenia.